When the breast cancer index returns to your office, that becomes the teaching tool when you sit down in front of the patient. They really relish the idea of looking at this data, as we've already talked about, as being an objective, informative decision-making tool. There are two parts to that test when you get it back. One is the prognosis over the next 5 years in terms of risk of recurrence. And the second, which is clearly the most important from the patient's standpoint, and why we're doing it actually in the first place, is that decision point, that tree, that the point of decision in terms of whether or not you're going to continue treatment or not. And it is a relatively simple analysis that points to either a low likelihood of benefit, for which additional therapy over the next 5 years is really not consequential in terms of additional benefit, versus a high likelihood of benefit, where clearly from the patient's standpoint, looking at the separation of benefit between the low risk and high risk is relatively convincing. When a breast cancer patient makes it to that 5th year, they are a motivated group to do what needs to get done. On the other hand, they don't want to do what doesn't need to get done. They're also anxious to get on with their lives, and be able to show them that analysis, both in terms of prognosis and the prediction of benefit, is incredibly important for them. And that prediction of benefit, that switch point of continuing therapy or not continuing therapy, is supportive for them in terms of getting on with their lives and avoiding the side effects that they've had already and avoiding side effects yet to come. And it's really a relatively simple discussion with the patients. They really look at that demonstration as really quite acceptable. There's been very little pushback in terms of, it says low, but I want to keep going anyway, or it's high, but I want to stop. Probably in a sense that the data is there is convincing, and second, that the patients are an educated group of women who have now survived 5 years and want to do what's best for them.
I think that when we look at this, these are patients, first of all, that have been under our care for several years now. They're patients that are used to hearing about studies and new tests and new technology because they're in our practice from all members of the multidisciplinary team. When we come to them now with a test that's been validated and really is the only predictive test out there with BCI, the patients are going to sit and have a reasonable discussion about this. And it comes down to risk-benefit. If we have a test result telling us that there's low benefit to continued treatment, the patients, knowing that this is validated data, are going to go along with that. That being said, the reverse is true. If we have a test telling us that they will derive benefit from continued treatment, although they may not be thrilled about continuing endocrine treatment for another 5 years, they will willingly go along with it and are more likely to be compliant. Again, there's validated data for this.
Yeah, for the 5 years prior, we talk about survivorship and getting through the treatment. There's certainly concerns and fears during those first 5 years. We will be telling the patients to win the battle, fight the battle today to survive the next couple of years. So when the next test or next treatment becomes available, you're there to participate. So I tell them when they reach that, here it is, here's that trial, here's that technology that we've been waiting for over these last 5 years. Had we not been in clinical trials, had we not stored your tumor, had we not survived these 5 years, we wouldn't be having this discussion. So here we are, here's the information, and it is precise and it is individualized, and it's designed to help you not only live long but well.
Well, we have to also remember it's validated predictive data, and that's critically important. I talk to patients about short-term and long-term, and you know, we want to get through the short-term so that we have the long-term, and that's really what it comes down to.